Oh, thank you very much. And I would say good evening to everybody, although here is afternoon and in some places it's morning, I can see. So good to everybody to this chat. It really is going to be a chat. A chat is not nothing formal what I pretend to do today. It's an anatomically sound approaches to the wrist. And this doesn't mean that I'm going to make a professorial, academically sound presentation. It's just a chat on different techniques that I have found in my life, my professional life, until I think some of them have become something that I truly believe that it's the right thing to do, but some are still under discussion. So that's going to be an anatomical presentation on approaches to the wrist. And needless to say that uh, I have to give thanks to everybody. Until now, usually my talks, I just want to share my work with everybody in the clinics, but those very seldom are advised or acknowledged. And those are Professor Manuel Llussà and Ana Carrera and Pau Forcada. It was with them that we started this project on anatomy, on persistent anatomy and dissection anatomy, and they were the ones who I think have the merit on many of my presentations that I'm giving to you. This is a book that it's out of stores already because it was sold out. It was so nice that we couldn't get it. And today I have a good feeling because it's going to be republished, but in English, and that's going to be a good thing to have, I think, because it's not the regular atlas of dissection. It's a dissection of one hand in which we come into all the layers and all the possibilities that you have with one single hand to see everything. So keep an eye on this because you'll see that it's something of value. All right. So today it's more kind of impressions or thoughts that I have recording in my life of as a hand surgeon. Several different approaches that I've been looking at, and those are the ones that we are going to be discussed. It doesn't mean that there are others or other approaches that probably would be more beneficial. And needless to say, I have to say that whenever something can be done arthroscopically, arthroscopy is the least disrupting method to get into the joint. And when something can be done arthroscopically, don't fool yourself, go for it. So we are going to do one on dorsomedial approach to the TFCC. The second it will be one anteromedial approach to the TFCC, another to the DRUJ, and then we'll do one on the scaphoid. I know that the other day there were some questions that probably will be answered today on how to get into the scaphoid and for the volar approach. And then we have the volar approach for the distal radius. And finally, we'll make a comment on dorsal wrist and all what happens whenever we have a denervation in our hand, in our heads as a possibility of complications. So this is going to be the plan. We are going to go through these 6 aspects, 6 approaches to the wrist that I think that merit some sort of validation, some sort of verification of what we have. Dorsomedial approach to the TFCC, this is one of those approaches that has been so lovely to me because it was published already in 2003 with Manuel Llussà. It came something as a surprise of how important it was. Well, in the beginning, we didn't pay much attention to this. Dorsal approach to the TFCC. As usual, I will start by some review of the anatomy. This is ulnar radius, a transverse cut. Obviously, you will see that indentation, this deep notch on the dorsum of the ulnar. That's where the issue tendon is. Let's work on the anatomy of here. Usually now we are working a lot in the lab. We're working on sections of cadaver fetal specimens, and this was from that 70 millimeters length CR length, a human specimen. And you can see this. Obviously, from here we can notice the fact that we have the dorsal and volar radioulnar ligaments surrounding the discus articularis, and as you know, between the two, there's no place where you say from here there's ligament and from there there's a fibrocartilage. Discus articularis is well embedded, and actually the role structure between the ulnar and the carpus for facilitating all the forces. The issue is in its notch and all the subsheath that covers the issue tendon. This is especially important, the fact that the issue remains faithful to the ulnar, while the radius is the one that gets all the tendon moving together with him. And then over the top, we have the extensor retinaculum covering everything and inserted into the radius, but not into the ulna. As you can see, probably there are some minor adhesions here and there, but basically the extensor retinaculum is kind of an annular ligament that goes around the distal ulna and becomes then the essential stabilizer of all the compartments on the radius, but not on the ulna. Extensor retinaculum. And obviously, because we have that rotation, that pronasupination of the radius about the ulna, we need some space between the issue subsheath and the extensor retinaculum. And that space is something that has been over there all the time, but until it was that guy in 1797 was born. Bourgerie was one of those nice fellows that we should know more about himself and excuse me. Jacob was the artist who did all the drawings. They were the ones who put emphasis on exactly the fact that the tendon issue has its own sheath that keeps it attached to the ulna and is independent of the annular ligament. The fact that there was that gliding between the extensor retinaculum and the subsheath, that was something that I think that was very important, or to me it's quite important now. We should acknowledge better. So it's this space that we have learned to call it the space of Bourgerie, Jacob in the case, and it's a space, it's a virtual space that separates the sixth compartment with the fifth compartment. Okay, let me see, because now foreign pronasupination implies obviously a lot of gliding between the two layers. One is extensor retinaculum, the other one on the top of the issue. The issue on the other side, as you can see. I have some problems. Let me see. All right. It doesn't work like this. Well, anyway, you have seen that in my presentation. It's the issue rotating about the ulna doesn't work as a video. And the problem that there is that colliding between the two structures is something that it's not understood well, because even in this case, I'm sorry, but I need to change this. All right, now, excuse me now. No, that's much better. So the problem is that whenever we approach the issue by violating the two of them, if we don't understand the fact that they glide one over the other, we are missing something. And obviously, if you do that direct approach to the issue, you are generating all that the adhesions that will probably be the ones that explain why the space of Bourgerie is reduced in gliding, and you have that lack of postoperative supination reduction. And this is something that I've been keen of looking at, and many times that I've seen patients with this. You don't find really an explanation why that patient could not supinate fully. In those cases, probably some of them were because they were operated without taking advantage of this possibility of the two gliding surfaces, one on the top of the other. And that was why in 2003 with Manal Yusa and Dr. Smith, she was from lady, a fellow that came from Alaska, and she was doing some dissections, and we prepared it, the surgical approach to the TFCC back then. And it's one that we are keeping faithful on that because it works very well. Okay, this is the approach. Usually we approach this through the fifth compartment, going straight onto these areas, and the way you can use be careful with, obviously there's a dorsal branch of the ulnar nerve, and then you go to release the fifth compartment, and then with that separation at the top of proximal or distal, depending on what you want to do. And you do that, and then you enter that space through the fifth compartment. And yes, obviously we have that. You enter this, and then you have to cut these fibers to get into that space. And the more you get into that space, the more you realize that there are no solution of continuity following the ulna, but the ulna it's somewhat free to rotate. Actually, it's the radius one that rotates. And this is it. So you can see now a extensor retinaculum has been separated, it's protected, and the subsheath of the AC tendon is protecting the tendon inside of the sixth compartment. And between the two, we have that space of Bourgeois that is still there. Okay, so now we have to the top, to the right, we should see the ECU sheath, and then we have the fifth compartment, which is basically the extensor proprius, the digiti quinti, and then between this and the fourth compartment, there's that artery. There's a lot of vessels. The fifth extensor compartment artery, it's called. It's the one that's important because it's used for some grafting, vascular grafting in the area. And this is the fifth extensor compartment. And between the two, we have the septum, and that the septum is quite thick septum that we should identify, protect, coagulate, and have it as a source of our incision, vertical incision. The incision is done to the bone, following that septum, 4th, 5. And then once you are here, at the moment that you feel that you are on the top of the radiocarpal joint, then you follow the fibers towards the triquetrum, towards the dorsal ridge of the triquetrum, and that's going to be a fiber splitting technique a little bit, so that you create here the basis for a flap. It's an ulnar base flap, and here at the axilla of the joint, we can go to the neck of the ulnar head, just to elevate that flap. And as you elevate the flap, you can open this by sectioning any connection of the capsule to that dorsal radio ulnar ligament. That it's really a ligament, and you'll appear this as you open that space. This is what you see. This would be the dorsum of that ligament. And all this, everything that we have distal to that ligament, until you feel under the surface of the dorsal radiotracheal ligament, all this triangle can be excised, and can be excised believing that there is no stability whatsoever in that space. If you think closer, this is the dorsal capsule, and it needs to be very flexible, otherwise pronosupination could not happen. So this space can be exerted, and as you excise this, and you can see the triquetrum, lunate, flexor, capillary, TFCC here and ulna, and this is the dorsum of the ligament that goes into the fovea. This would be probably the recessus peristyloideus, and this probably is the meniscoid on the volar side that can be seen also from that. And what I like from this is that even though this approach allows you examination, perfect examination of the dorsal ulna, the dorsum edge of the TFCC, all you can see here also the recessus peristyloideus and the meniscoid, meniscus small meniscoid and everything. Despite that, you still have the ECU tendon in its own compartment. So it has not been violated. You have not seen it. And as a matter of fact, I would say that if you need to go and see that tendon, then you should progress this dissection, intra-articular progression towards the tendon. And then you may release the tendon from inside, never from outside. It's been said that it can be done outside. I don't think it's a good idea. I think that if you need to do a tendon synovectomy, you'd better do it this way, from an approach inside. Um, oh, yes, now it works. All right. So the issue tendon still remains in its own compartment. That means that we are well off in that space, and then you can do whatever you want. This is a system I've been using quite a lot of time of how to reattach an unstable TFCC into the fovea. In this case, I had to resect a little bit like a wafer, the distal portion of the ulna, so that just to make the more approximated the TFCC towards a distal insertion into the fovea. And here you can see the knot. Usually I go towards this place because in this place, instead of going into that area on the neck of the ulna, you have enough space. You may have that suture very solid repair can be done there. And this is schematically the representations in that place. You can see how the dorsal capsule is reinserted even to provide that tensioning, that trampling effect to the TFCC. You use those core sutures between the dorsum of the dorsal capsule, and the dorsal of the TFCC. And by doing that, you have that capsular repair done to the left. And then you have still the extensor retinaculum that you have open. Remember, in that in that T-shape incision, you can repair that. Every tendon comes into place into each space, and then the skin that is sutured to the right. That's a type of incision I like to use. Except that probably you may use other techniques. This is quite useful in my case, but probably it's because of a school, because I'm from a school that we zigzag almost everything. Well, this is a case of a patient that I did a long time ago, one of those repairs to a 1B avulsion type of a TFCC that was repaired 17 years ago, and you can see that it worked very fine. On the incision, still it's hardly visible. I would say that it's quite normal. So, and if we have that, and we are so keen on that and that approach, why should we test an anteromedial approach to the TFCC? Well, the thing has several reasons. The anteromedial TFCC was something that was suggested to me by Hisao from Tokyo, no, from Nagoya. And yes, well, there was a discussion, and also we did some work with Elizabeth Haggard, and those are two particular publications that we did on surgical approaches of the DRUJ, and one of them was mentioning that with quite an extension. And the reason for that was not other than to prevent damaging the innervation of the TFCC, because we must admit that the dorsal branch of the ulnar nerve is not enough, that we are sectioning the posterior interosseous nerve every time that we go from dorsal to palmar through this approach. And the ulnar nerve provides all the bolus innervation on that system. And between the ulnar nerve and the dorsal branches of the ulnar nerve there is the perfect place for getting into the joint. And that was something that Hisao Moritomo put onto the market by saying, gee, we should use this more often. And the only problem is that you need to know the anatomy, but that's really not a problem. So I would say that the anatomy is particularly very nice to do it through this way. And I'll show you how we do this anteromedial approach to the TFCC and when we are using it. The dorsal is used basically whenever we have to check on the issue integrity of the subsheath, and everything else is basically an avulsion type of TFCC avulsion. Then I go palmar. Usually we use that incision, again, schematically, is on the anteromedial approach. That means that whenever we get into the crease or more or less proximal to the pisiform, we go on that into that zigzag. But again, as I said before, you can do whatever you like the best. Then be careful under that incision. You have to be very careful about the dorsal branches of the ulnar nerve, and be careful over there because deep inside of that fat tissue that you'll find here, you have all those fibers of the extensor retinaculum that are coming from, as we have seen on the dissection on the back, come around the medial corner of the breast and get into the pisiform inserted, also inserted into the proximal, into the medial aspect of the flexor capillaris and also into the medial aspect of the abductor digiti quinti. And then once we are there, just by blunt dissection, we get into the pisiform, we find the pisiform, and over there we can follow that trend. We perform a pisotracheal capsulotomy, a medial one, that allows us just to derotate the pisiform in a way that we are opening gently the joint. I say gently because, as a matter of fact, you have to be careful because under that rotation, you have the ulnar nerve, ulnar artery, etc. On the dorsum, you have all the dorsal branches of the ulnar nerve as well that they emerge much proximal to that. And then by doing this, you uncover the volar surface of the volar capsule. And over there, you know that there is the ulnar nerve innervating the volar surface, as we have seen before. And then you have the ulnar carpal ligaments, ulnar tricutal, ulnar lunate, they all emerge from the TFCC. And this is why I'm suggesting always to perform that ulnar base capsular flap here seen in gray, in green. This is the zigzag incision I use. This is in a cadaver specimen. You can see the dorsal branch of the ulnar nerve to the right. The big branches, there are two branches here. Sometimes it can be three, sometimes only one. But the most important thing is not that one. Most important are those little branches, are those articular extensions that come more or less into that area. And those are the extensions that innervate the axial, the TFCC, the volar ligaments, etc. And this is the area where we are placing that capsulotomy. And we need to do it as proximal as possible to avoid all these branches, little branches that you will have here. By opening this capsule, then what you have is this, and then you can see the volar ligament, and the articulation of the ulnar carpal, the distal ulna into the ulnar sigmoid notch here, all right? In a case where we want to preserve that articulation, then we should do the capsulotomy this way. In the case I wanted to do an excision of the ulna, then I would not go this, because this is quite dangerous for those branches here. Then I will go probably the other way, what Bill Kleiman calls the silhouette capsular approach to the DRUJ. The case you can see here through that specimen, you can see that the fovea, you can see the prestellar recess also in that direction, in our direction. The palmar radial ligament and the sigmoid notch. Everything is in there, yeah, for you to do whatever you need basically. And the more used you get to that volar approach, you will see how useful it is for you to do things. Obviously, if you know how to do it arthroscopically, you can go there arthroscopically, but this is for more significant type of injuries that you may have. In this case, I excise all those ossicles that were in the ulnar styla. They were making a lot of pain to the patient. A long time ago, had an accident while he was a child, and had to resect that. Through the volar approach, it's small, but you can see everything from that approach. All right, and then the next one is anterior approach to the DRUJ. Why should we approach the DRUJ in a different way? Well, obviously because we have here the big enemy, I would say. That the ulnar nerve, it's not an enemy, but you have the artery, the nerve here, you have in this area where that cut was missing, the FCU. And this is the DRUJ. And very often we need to approach this area of the radius. We need something that gets into the anteromedial corner of the radius, and you need to know the anatomy. Well, the anatomy is quite evident that you have to go between the flexor tendons on one side and the neurovascular ulnar approaches. Here we have this case. I think that each one that I showed to you the other day when we were talking about these locations, this is a representation of what you wanna, you'll see here, the pisiform, the flexor retinaculum, the zigzag on the front, and then we continue proximal this way. This is Guyon's canal, basically. The pisiform would be here. And then once you have resected that, you look at the nerve, you look at the veins and the two concomitant veins around the artery here. This is the ulnar neurovascular. And then here you have the proximal portion of the tendons, flexor tendons going to the fourth and fifth digits. Okay, this was for the case that of dislocation. Obviously, through that approach, we have a wonderful view of the deep floor of the carpal tunnel. You can see here the rent. This is the proximal, the medial lunotriquetral anterior ligament. And over there, we can look at the distal surface of the lunate dislocated. And this was here, it was under the examination. And here you can see it rotated, the lunate in place. And now you can see the rent and how well you can set sutures here if you want to do it. What I wanted to share with you with this is precisely something very old that my senior partner, Alberto Luke, told me and taught me, is the fact that the carpal tunnel is a pulley, and that pulley needs to be repaired whenever there is some instability, so much instability proximally, that allows that bowstringing. That bowstringing is a very negative consequence of having lost the effect of carpal tunnel as an important pulley. We should understand that because it's not that, it's not that frequent. I'm not saying that this is terribly frequent, but I would say that you should keep an eye on always understanding the wrist, not only as an articulation, composite articulation, but also a system of pulleys that need to be preserved. Here you can see that in that cut, sagittal cut, all these elements. And obviously he was telling me that by saying, well, you see, this is the flexor retinaculum, this is the median nerve, and this is the artery, the ulnar artery. So there is no much space here from one and the other to take the risk towards the nerve or take the risk towards the artery. So anything endoscopic here, it can be done, of course, it can be done, but needs to be careful on not injure anything like that. Because if you do it endoscopically, you can, if you are from inside, you can make a, you can injure that ulnar artery, and you do it, if you do it here without knowing where the median nerve is, you could harm this. And that's the way we do it. Just we go there, we go into the carpal, into the Guyon's canal, and then we section this in this place. How we section it? Well, probably you have seen before. We section it just following parallel to the hook of the hamate, more or less leaving on the ulnar side 1 or 2 millimeters of tissue to later repair with the proximal extension of that incision that's towards the pisiform. As you can see, what I'm trying to do is this, and just the cut. And this is the ligamentoplasty that was basically one of the core messages of Albert Luke's PhD in 1980. And he was so green, so great on that, that he convinced me that I had to do it. And I've used this technique always all my life, whenever I have to open this or whenever I need to provide some stability to that pulley. So remember the ligamentoplasty by Albert Luke, not to do it in all the cases. Obviously, most usual cases, they don't need to do that. But if you have some instability of the flexor tendon, some bowstringing appearing, you then should pay more attention to that repair or that reconstruction of flexor retinaculum. Okay, so let's continue. Let's move on to the next incision. Next, well, this is in a cadaver how we perform that sectioning. You can see that there's S-shaped sectioning of the distal part. I would say that this is a hook of the hamate, more or less. We go to rectangular. The nerve usually is here, goes here, and exit there. So we are far away, probably half a centimeter from the nerve, and then we get into this. And then obviously, yeah, you have that. And also I have a case for to show you. You can see that hour of glass construction here of the median nerve and how much it can be preserved, even though we have some providing some stability between that ligament. Here it's a plastic that opens the carpal tunnel and protects enough. What to say about the anterolateral approach to the scaphoid? In this case, what we are trying to show is something a little bit different. It's an anterolateral approach to the scaphoid, and remember that we do that without going as it was said by Otto Russe, a German that published that in 1954 and then in English in 1960. He published the fact that probably the scaphoid could be approached by just going towards Flexor Carpi Radialis, an incision to the FCR that then protects the tendon and then goes deeper until it says finding the capsule. And it says that when it finds the capsule, then you open the capsule, you'll find the bone after this. Be careful because it's not that easy. I mean, this is the Flexor Carpi Radialis tendon. Once I have opened this, and see in this case how close it is, the sensory branch of the median nerve towards the Flexor Carpi Radialis, FCR. It's so close that it's unlikely, or it's not unlikely that we may section the tendon, particularly because it's well within the thickness of the sheath of that flex, the FCR. That from one side, and on the other side, if you go straight into the tunnel, so into the tendon, so that you can see this tendon like this. For sure, to get to the scaphoid, you have to section again longitudinally the sheath of the FCR again until you find the capsule, and then again you are sectioning. So, what I'm trying to say is that you are creating 3 scars that will produce excuse me, that will produce a scar tissue formation around that tendon. And it's not unlikely that by doing that you have a Flexor Carpi Radialis fibrosis, that it's adherent to everything with the tendon. That must be a painful situation that I don't like. That's why I'm always advising to get see, these are the ligaments, the 3 ligaments that usually you must get under the FCR sheath. Those are the tendons that you'll find. And you will not see that as in this direction. You will see that covered by all the capsular tissue and fibrous tissue, loose connective tissue that's covering this. And it will be difficult to repair those ligaments if you don't know that they are there. And that's exactly it. I mean, out of sight, out of mind. You don't see them, you will not look at them. And this was actually the engine of that work that we published in 1988, in which we found that most the cases that we had we had approached palmally as compared to the ones that we approached dorsally, that we had not corrected the DC deformity nor the carpal height. And we proposed that, and actually we published in Journal of Hand Surgery in the year 1988, in which we found that indeed that approach was careless repair. Let's say a careless repair of radiocarpal ligaments was in detriment of we were creating, in fact, a lot of fibrosis using that careless non-repair, I would say, one repair radiocarpal ligaments that we did. And that was the reason why then when we had the chance, we did some work on the lab, and we found that going by by a fiber splitting technique along the radioscaphocapital ligament, and then curving towards the right side. Um, uh, I'm sorry, I cannot follow the pointer here. Oh, no. Well, anyway, let me explain. So as you get into more or less at the volar side of the capitate, you rotate, you curve your incision towards the right, following the scaphoid tuberosity, and then you resect or you start detaching the volar ligaments from the radial, here. No, okay, let's take this out. I'm stuck. All right. Yes, yes. So basically what I'm trying to say is that always first try not to get into the FCR tendon sheath. I go more towards the radial side between the FCR tendon sheath and the radial artery. That's the way. We are surgeons. I mean, we should be careful with that artery, and you should not have any problem by just going into that. And usually what we do, we open first the superficial fascia. There you have on that arrow, you can have the branch, the polar branch of the radial artery that is there always, and you can dissect this carefully. And this is another specimen. You can see the volar incision that we always zigzag, and go for the radial artery, and there you have the branch. And the branch is ligated, and then you have everything under control under the first compartment to open this and get into the capsule. Once you have controlled the volar, the artery, you have the capsule there, and you only need to understand where the tip of the radial styloid is and the direction of that radial styloid towards to the capitate. So you have that incision here. It's marked to the right in that schematical view. It's along the distal one third of the distal radius towards until you have sectioned that, and then you curve this into towards the centrum, towards the capitate, following the fibers of the radioscaphocapital ligament. And once you have more or less into the depth, or I would say the floor of the FCR, then you go to the right until you uncover the scaphoid tubercle. And by raising that flap, the flap that you see up the top of this guy, and by raising that flap towards the right, and then proximally as much as you need proximally, you have that beautiful exposure of everything. Oh, there I have it. Thank you. No. This is another specimen. Now I feel much confident if I have that. This is the proximal insertion of the radioscaphocapital ligament along the fibers of the radioscaphocapital ligament. And then I curve here and I can open this flap. This is the distal flap. This is the proximal flap, and this is how much bone you can expose from here. This is STT, this is scaphoid tubercle. This is one of those big holes that they are there. They say that it's for blood supply. It's not true. There are many others on the other side. And as long as we don't go inside to this space a lot, as long as we don't penetrate this a lot, there's a lot of vascularization coming from this. This is very anterior from the lateral side. And there's enough vascularization for the proximal pole. Okay. Now, another next question is how you do to obtain that graph that you can use. Of course, this is an area where we are exposing. Now, we will see this. We will see that later. But we will be exposing the distal radius quite a lot. That's for the radius union. I don't know why it is here, but now you have to recognize that. Open here, we have that corner, the anterior corner, anterolateral corner of the radius. And it's a corner that is quite distal in the sense that over here the bone is less cortical and much more cancellous bone, and there is the enough quality as to use this for a graft. And this is something that we publish with Luis Aguilera. And you can see that this is the idea. The idea being is that how to obtain a graft from a local bone that does not generate any trouble to the rest, and can be covered. We can be covered because here you have the pernary quadratus, and here you have the brachioradialis tendon inserting into that lateral aspect onto the first, within the first compartment. You can obtain this as a good material to have one of those um, non-union that you have to resect completely the scaphoid, and you have that gap. You may use that as a source of your graft to do one of those sandwich plastics that they call it. This is those two cuts, one transverse cut on the scaphoid on the radius, just to see that this is the scaphoid, more or less the curvature that you need here of a graft. And the quality of the bone is quite similar. This comes from the same specimen. And that means that this is the graft, as you can see. And it's kind of rounded exactly the same way, exactly the same curvature. And that means that that graft into that area, on theory, and from that work that we published some time ago, it can be used. And this is one of those CT scans in which I am showing what the quality of the bone would be once transferred here. And we are using only one incision. This is the graft taken here. You can see the graft. Cortical and although the cortical here, since it's quite distal, it's not that bad for that purpose. You have all the quality. Usually I tell people not to go through the dorsum because then the x-ray is ugly, but not because it could not be done. Here is the graft, and it's used then distally to be inserted into the scaphoid. And here you can see, usually I use this, or can be used also screws or headless screws or whatever. And this is another case where in a patient, this fracture has been exposed, and you can see how well we can see proximal and distal fragment of this scaphoid, and why this approach can be used. And still all the vascularization comes from that corner and even farther down into the dorsolateral aspect of this scaphoid. This is a very nice approach that I've been using for several years already. Okay, so, and I say this is a vascular sparing approach, but also it's somehow it's a nerve sparing approach, because the nerves that come into that area come more distal, and therefore there are not much of a problem of nerves in the volar surface. And then let's jump now onto the anterolateral approach. So let's not move far from here, because now I'm going to explain how we can use this knowledge, or this dissection can be used also to understand how to approach the distal radius. Distal radius that here you can see in that specimen, nice specimen. Usually everybody comes to place into the Henry's anterior approach to the radius. But be careful, because again, I don't like going radial to that FCR. Usually what I like to do, let me take these pictures out. What I like to do is to leave the flexor carpi radialis on one side and the radial artery on the other side, but not like this, as it shows here, that goes into the sheath and creates that match. No, I prefer to go more lateral, to go to the radial artery. As you do that, let me see if I can find you. All right, that's it. So flexor carpi radialis, and then you open this superficial fascia, and beside the superficial fascia we have all the radial artery here. You know how to treat arteries and veins. This is the volar. a recurrent thinner branch of the radial artery. Here's a FCR. And going through this space, we can go as proximal as we want until we get into the pronator quadratus space without having to damage that. My problem is that I'm not sure why do we need to see the FCR to get there. I'm not sure. This is the artery, the radial artery here. And then you can see now we are elevating here the pronator quadratus muscle. This is the volar surface in one dissection that we were keeping some material into the little vessels just to see the vascularization of this area. And this is the idea that Jorge produced. He said that always you need to cut the brachioradialis. You need to cut it so that to liberate the proximal, the metaphysis, and by pronating the metaphysis, you can see that. I don't think that's necessary. I don't think that it's. And from now on, I'll show you how we use it. We use a very lateral incision till here, then a little bit of a zigzag, just for comfort of us. And flexor carpi radialis just at the front. You can see that we are not going for the FCR, we are not going radial to that, almost to that, we are going more radial towards, we go to the artery, and then we are now here between the volar surfaces of radius and the lateral corner with the first compartment here. And this is the place where we are cutting the bone. This is the place where we open this and we elevate the plexus, the pronator quadratus in block from the bone by following this incision. And we elevate it in block and as lateral as possible so that we can use then the brachial radialis tendon that is inserted just right there. We use the brachial radialis insertion as a point to provide the stability to the PQ muscle once this is completed. You can see the pronator quadratus muscle that's elevated here, subperiosteal elevation. We can keep almost all the muscle in a way that will be used later on. By elevating this, then we are getting all these volar surface of the distal radius open exposed. And brachioradialis is here still inserted into that point. At that point, and now I would like to show that the slide that we saw before. At that point is when, obviously, if you don't cut the brachioradialis tendon, probably you will not have the way to reduce the fracture conveniently. And in those cases, instead of going to that section, he uses a step cut section of that tendon so that he can repair later on a more distal way. What I like is just, I go like this, subperiosteally I elevate all the periosteum all around this until I am on the floor of the second compartment that can be elevated as easily as that. And can be elevated, and you don't find really that big arteries that need to be preserved or coagulated. No. This is what you see. This is, you can see the floor of the first compartment on the lateral side. This is the floor of the distal metaphysis. Over there, there's the capsule. And here you can see all the floor of the second compartment. And back then, just under that Hohmann elevator, you can see the Christus tubercle. So the view that you have that, it's so incredible that you can approach this almost volar and dorsally, reduce everything. And this is a case that I wanted to share with you. It was one of those students that came here with an outstretched hand. He fell and he had a cast immobilization, and he was already a malunion at a time with a lot of problems with the median nerve and deformity and so on. And in fact, it had already been healed, displaced. And what we did was to open this. And you can see that we mark here the origin of the bone that was previously fractured, here. And then all this bone was new bone formation that we had in that scar tissue, and we removed that. and we put the plate, and this was it. Quite a simple procedure that allowed us in this case to make a perfect reduction, and you can see that the results almost 1 year you were very good. So it's not the technique; it's the fact that we can see a lot of structures through those approaches without damaging that. This is another idea that we had with to get graft on those instead of going as before that we went into that direction. We took that drawer of a cortical cancellous bone. It's like a drawer, as a matter of fact. What we are doing here is taking the drawer out, keeping it, and then after the osteotomy was done, it's the same tissue that it's reverted 90 degrees and then inserted as a graft in the dorsum. That was done here in this case. You can see that the drawer was emptied, and then we placed the plate, the bullet plate that was used as a matter of fact, was used just to accommodate everything, and that was giving us the correct, the good separation on the dorsum of that bone. And we could insert this into that space. And this is, you can see the same patient preoperative now, 13 months down the line, good result. And finally, this is something that I have mentioned here and there, and something that people usually don't understand, don't remember. The frequency of flexor carpi radialis brevis is not zero. We're talking about an incidence of almost a 3% incidence of having this unusual muscle. It's an unusual muscle. It's called flexor carpi radialis brevis. It gets into the zone where the pronator quadratus muscle should insert, and inserts here in this area instead of here where it would be the normal. And instead of that bone, that muscle, when you open, you find fibers in that direction, and you start thinking that maybe this is the flexor pollicis longus, and you start messing around trying to find your surface, the usual surface, or use the usual transversely oriented fibers of the pronator quadratus. This is not it. Just know that exists, and if that exists, you may just cut this here, can remove that, and you may proceed exactly as before, except that you will not have the pronator quadratus to cover all the plate, but only on the ulnar third of that plate. Flexor carpi radialis brevis, 2-3%. There are many cases that are there just disturbing. It's not a tendon that cannot be used. It can be just excised and nothing happens. All right. And now we go back to the dorsal approach to the wrist, and it's important to go there and realize that how easy sometimes we perform sections without noticing the consequences. And the consequence in that case, if you want to excise the synovial cyst, or you want to go to insert one of those screws into the scaphoid, sometimes we create incisions that are not thought of to be done without damaging all those radial facing branches of the pin, the posterior interosseous nerve. Just a call for to be watching this. If instead of this you use the reverse type of incision, you're doing exactly the same without violating all these dorsum of the breast, and nothing happens. In that case, just a call for advice. For don't be shy, and try to be elegant in your capsulotomy. That you can do a capsulotomy that allows normal innervation of the dorsal capsule. But it was not that what I wanted to talk. I want to talk more specifically about the dorsal approach. The dorsal approach is typical. All of you know how to do it. Usually it's taking the third compartment, fourth compartment, the septum between the third and the fourth. The third is the extensor pollicis longus. And this is the way we do it. This is the dorsal. tendons into the fourth compartment on the dorsum. This extensor retinaculum has been opened just by following this. And this extensor pollicis longus, and this extensor carpi radialis brevis and longus. This is the brevis, this is the longus, and those are the extensor digitorum communis. We open this and we have the capsule. And then the question is, as usual, why should I open this? Of course, you can do whatever you feel like, but in our way of thinking, that you know that we are more keen on all what matters about proprioception, about ligaments containing mechanoreceptors, all the mechanoreceptors sensation being transferred by the posterior interosseous nerve. We don't like to see that nerve cut here, and that's why we use usually this incision. This is the incision that was always proclaimed by our friends Bishop and Berger, Dick Berger and Alan Bishop. They proposed to go just across the dorsal intercarpal ligament. Then those 3 points represent the anatomical landmarks to go from the middle of the dorsum of the fourth compartment into that. And then by this, opening this in that direction, there's no point that you cannot, you can save that nerve. The nerve will be cut, absolutely for sure. Our proposition, that actually it was not mine, it was Elizabeth Haggard's proposition in one of the studies that we did together. It was, instead of going towards the distal rim of the radius, towards the radial styloid, why not doing this? It's the same principle. I mean, the fiber splitting technique. And once here, instead of that, just go proximal towards the radial styloid, and you can raise, it's a proximal base capsular flap, that it will be proximally rotated so that you can see inside, you can do a lot of things without damaging the posterior interosseous nerve. And this is a preparation by Claudia Lamas, a dear friend of us in Barcelona. And she did all those preparations together with Dr. Lusa, in which you can see all the vessels going into that flap. And all those would be preserved as well, while if you were using the original flap, you would cut these, you would cut many of them, would be just cut without having advantage of that. So my good advice is, why don't do it this way and not the other way? It's just the same. If the case, it's good. And this is the case that we did with Elizabeth. Dorsal radiocarpal ligament is now sectioned following the fibers, and then along the dorsal intercarpal ligaments towards the radial styloid. And then this is the flap that we elevated. We are going proximal. And this is on the dorsum of the scaphoid lunate triquetrum. And this is what you see whenever you have done that. I mean, there's a lot of exposure, and you can even open. Oh, sorry, this has been changed. This is a scaphoid, this is lunate, and this is the fracture that we found. So there's, with that flap elevated, there's a lot of room for you to go inside and to see things, of course, if that needs to be done, if you had something differently, and see how then, by placing that flap back to the dorsum of the scaphoid, and you still have all this nerve, and all this nervation, it's preserved, not 100% of course, but you may sound that this tissue will be there for a while, and particularly if you leave some tissue here, you may get all the information that you had before on this remnant of the ligament that was inserted into the lunate. You may still have that if you provide over the top of this remnant of rupture, if you bring back that capsule flap over the top of this scaphoid. This is my final idea. It's not an idea, as a matter of fact. Is instead of going this way, maybe go this way. Yes, you can do that. Particularly important or particularly useful in prosthesis, you can go into the radial styloid along the dorsum of the capitate, of the neck of the capitate. You may go, instead of going this way towards the original, you can go following the ACU tendon into that space. And once you open that flap, you have all this view, you have all this view, and whenever you bring back that, you still have all these flaps still innervated. How much important is innervation in those cases? Well, probably we should discuss a lot, but it's not the goal of today. Only to say that as a final say that you may connect the dorsomedial TFCC approach and the dorsal approach. You may connect them by going this way. This is the one that we just saw now. This is the dorsal capsule flap dorsum. Well, you can reconnect this with the dorsum of the DRUJ. You may open this. Will be open this way. This way, and that's what you get. You get as much as you can and in open way. Dorsal of the scaphoid, the ulna, sigmoid notch, TFCC, lunate, the triquetrum. This is the capitate, and no, sorry, this is the hamate, and the other one. And the funny thing is that whenever you are closing this, you have, remember the solid and big dorsum septum on the fourth or fifth, and then you have this following the dorsal radius brachioid ligament, the dorsal intercarpal ligament. All of those allow you a very solid suturing techniques, but by uniting fibers, parallel fibers on both sides of this injury. And then here you can end up by closing the capsule perfectly well so that you can almost mobilize this automatically without, or at least having harmed the posterior interosseous nerve as much as you could. And finally, this is one of those things that it's a present for you. Remember, we have always said that a doctor who is not an anatomist is not useless but harmful. And without anatomy, there is no, well, all those sentences we have heard that occurred, that somebody said, we were mentioning Gubarev, finally found out who was the one who said everything. That was from a paper in Stanov that in 1975 was published in Acta Anatomica. He is one of the big professors, or was a big professor in Moscow University, and he was the one who said all those things, referred to Yefrem Mohin, who in the 19th century said something that we always have believed as a very important quote. The doctor who is not a good anatomist. He's not only useless, but harmful. And in that case, I think that this is exactly what's going to happen. If in the laboratory of anatomy there are more material, more money spent on that, people will not like to come to Barcelona and help us in that. And it will happen as in this case that it was a dead man who was taking a drawing of a dead man. And that's really something that we should not allow to happen. Well, thank you very much, friends.